for PrEP or pre-exposure prophylaxis, I think what we're really looking at is anyone that considers himself to be at risk for HIV acquisition. You know, the CDC has come forth with a set of guidelines that sort of lumps people into categories. So high-risk heterosexual sex, high-risk men who have sex with men, and then intravenous drug use. But what I think is more important with that is what does the patient perceive their risk to be? And I think that message has to get out that there is a drug out there that can prevent HIV acquisition. Most of the times I'm asked, you know, what's the latest status on the HIV vaccine? And my comment back is, it's still in development, but why focus on the vaccine when we have a drug that can prevent HIV acquisition? And I think that's a message that's just not getting out there like we would like it to get out there. So I think any person at risk, or if they feel they're at risk, really should and would be a great candidate for pre-exposure prophylaxis with Truvada. So the safety and efficacy of Truvada, or the components, which are emtricitabine and tenofovir disoproxil fumarate, I think when you look through all the trials of pre-exposure prophylaxis, we see, like we see in the HIV treatment paradigm, people have a little bit of nausea when they started, but that nausea tends to go away. When you look at long-term, and again, when you look at Truvada, where we see the toxicity is really long-term, but we know that most patients are not on Truvada for long-term when they're using it for pre-exposure prophylaxis. Right now, what we see is that we can't use the newer version of tenofovir, which is tenofovir alafenamide. We're still lacking data on that, and we're waiting for, there's 2 large clinical trials going on called Discover, and we're waiting for those results to be published before we can feel comfortable using the newer form. I think when most people think of Truvada, they think of kidney toxicity and bone toxicity. We do know that long-term that can occur, but again, as I said, most people on PrEP are on it for a short term, most around 6 months or less. And we do know that once you stop the Truvada, the bone loss does reverse. So I think providers have to really get the message out to patients saying there is something. One of the things I've realized through the years is that most providers are unaware that there is a drug to prevent HIV acquisition. So I think it's very simple. They need to know that it exists. They know it's safe, it's efficacious, and then be willing to talk to patients about it. And I think if they're not willing to talk and they're uncomfortable, then you need to refer. And I think that's the thing. The answer is to not talk about it, because if you get someone who goes out and acquires HIV, then they're living with the virus for the rest of their life, and they're forced to take antiretrovirals. Whereas if you have a drug on a short term, maybe someone's not in a relationship and is dating, or they're not ready to settle down yet, and here gives them a chance to protect themselves from acquiring HIV. So I think providers really need to give just basic messages, and if they're uncomfortable, refer the patient. I think the biggest challenge with PrEP is for the patients who don't have a lot of sexual activity. So the recommended dose right now is daily dosing of Truvada. The problem is not everyone comes in, and people come in and say, I have sex maybe once a month. Do I really have to take a drug every single day when I may only have one sexual encounter? And there is data on what we call on-demand PrEP, which would be given 2 doses right before the sexual activity, one 24 hours and then one 48 hours afterwards. And there is some efficacy out there that this does work as well. But right now the recommendation is still to use daily dosing. And there will be in the future injectables used as pre-exposure prophylaxis, but currently right now we're limited with just Truvada daily.